Hi, everyone, and welcome to today's webinar, Accountable Care Academy, Risk-Based Payment Methodologies. We'll get started in just one moment. All lines have been muted on entry. Please use the chat box to submit your questions. And with that, I'll turn it over to Jennifer Nolte.
Thanks, Julie, and good afternoon, everyone. We hope that you're able to take a few moments as part of your day and your week to join this session. We know that before COVID that the Accountable Care Academy has been a popular training that NAC has offered in various formats over the years. And one thing that has consistently come up over the last number of years is this discussion around risk and risk-based contracts, and basically what health centers are able to participate in, what should be looked at, what are some other items. So I think that what we need to do is consider looking at these sessions. You can, again, we've offered them both individually as well as a group, as a series. So we have today, which is the general considerations under federal law and FQHC payment protections. And, or I'm sorry, that's not today. That's in 2 weeks. Followed by the value-based payment and contracting safeguards. And then finally, we are going to have our field representative stories from 3 different states across the country that will give some insight into your peers, into what they've been doing in this, and we call it a journey, because for those of you who have been participating in any type of value-based care or even in an alternative payment methodology, APMs, anything in those regards, that you know that it's not just a one and done, that this is a journey. And there are so many different components to this that it's not easy and that it does take time. So we're very lucky to have Adam Falcone from Feldman Tucker Lifer Fidel to present on this series, and then he will help to mediate or moderate, I shouldn't say mediate, but moderate the representative stories in the end of July. So in addition to that, we will be providing some tools and other items that you can, like other resources to help to reinforce what is being offered during these webinars. So those things will be also provided on an ongoing basis as well. And again, for those of you who have colleagues that maybe could not join today, we are recording these. These will be archived and will be made available. All 4 of these will be made available for future use. So at this time, I think that we could turn it over now for the risk-based payment methodologies to Adam Falcone.
Great, thank you, Jen, and the rest of the NAC team. I'm happy to be here today presenting to you, as well as the future webinars. Today's webinar topic is risk-based payment methodologies, and certainly I will try to also tailor my comments in light of the COVID-19 pandemic, public health emergency, and particular considerations in light of that pandemic that might affect how you approach or pursue risk-based payment methodologies, value-based payment arrangements, any of those sorts of accountable care arrangements that you are contemplating to engage in with payers or with other partners that you might be part of an ACO, an accountable care organization, or an independent practice association like an IPA. I will do my best also today to make sure if I use any acronyms to define what they are. Our intent really here is to have each webinar build on the prior one, and this is intended as a series or a package. So when we get to the next 2 webinars, I will certainly anticipate that you've heard this webinar as well, so that it will all make sense to you. I'll also be leaving some time, hopefully at the end of the session today, to take some questions as well. So let's proceed. All right, that's me. I have not seen my picture blown up that big for a long time, so I'm going to move quickly past it because it's embarrassing. All right, this is my law firm's disclaimer that you've probably seen before. If you want legal advice, basically, you have to engage an attorney. This is just for educational purposes. Let me share with you the agenda for today's webinar. Essentially, I'm going to give a little bit of some background about what it's like to engage in risk-based contracting activities and how you might think of that to make taking risk a little less scary for some of you. Next, I'm going to talk about the HCP land framework that defines different types of risk-based arrangements with payers. It's sort of a common vernacular or definitions that are applied to different types of risk-based arrangements so that we can all use sort of the same language to describe potential arrangements and what they look like. Next, I'm going to review a few of the national Medicaid trends that I see in contracts between state Medicaid agencies and MCOs, or if you're in states that call them other things like coordinated care organizations, CCOs, or whatnot, what those requirements look like in regard to alternative payment models or value-based payment arrangements. And then lastly, I'll offer you some concluding thoughts. So for those of you that are intimidated by the notion of taking risk or engaging in risk-based arrangements, or simply asking, what does a risk-based arrangement mean? What does risk mean? It's important to think about payment arrangements as all essentially having some degree of risk in them, including fee-for-service. The only exception to taking risk in a contract or an arrangement with a payer is really cost reimbursement, where there's no risk. You get paid for all the allowable costs. And yet you do still have some risk, right? Just like you know under your federal grants, you can only charge the grants for those costs that are allowable. So it is conceivable that even if you have a cost reimbursement contract with a payer, which sounds great in theory, they could deny or disallow particular costs. So if you really are thinking about it, any kind of payment methodology, whether it's cost reimbursement, fee-for-service, PPS, or something more like capitation, they all involve a degree of risk. It's just a matter of degree. Cost reimbursement, as I mentioned, involves really no risk except for the costs that are allowable. Fee-for-service or PPS offers limited risk. You know in advance what you're going to be paid for service, if it's fee-for-service, or per visit encounter, if it's PPS. If your costs exceed that amount, you're taking the risk there that you will incur a loss. So that's a kind of risk, financial risk. And then if you're in capitation, you get a bundled per member per month amount to cover a scope of service. And then if your costs exceed that scope, you're taking that financial risk. You can taking potentially a loss. So risk is relative to the payment methodology. So I would say don't be intimidated by taking on more risk. The key is being able to manage that heightened or additional level of risk so that you are not incurring losses for the amount of risk that you're taking. And as we'll talk about today, there are some very important or good reasons for why a health center might want to contemplate engaging in risk-based payments that involve capitation or involve some risk for the total cost of care for a population. And particularly today, in the COVID-19 pandemic, many of you probably appreciate the fact that if you're paid on a capitation basis based on an expected volume of patients, that does provide you some degree of mitigation in the event of a pandemic, because now you're not needing to generate particular encounters to generate payment from a payer. You are paid on capitation on an expected amount of utilization, which may or may not materialize during a pandemic. We'll talk more about that later. Another way to look at risk is really by the payment model. Many of you have probably seen this chart, this graph before. On the left-hand side, it shows the degree of financial risk, and then on the bottom x-axis, as we all remember from elementary school, the degree of integration or your accountability in that payment model. So at the lower left-hand corner, fee-for-service, little financial risk and little provider integration, and then as you move stepwise up the ladder, you're increasing your accountability, and it does require typically some integration and some activities with other providers usually as well to make the payment model work. So P for P stands for pay for performance. Those are incentives, financial incentives that you're typically paid for hitting or achieving certain clinical indicators. PCMH, patient-centered medical home payments that some of you might receive for achieving qualification or certification as a level 1, 2, or 3 medical home. Condition or service line is really bundled payments. So you might think of PPS as a bundled payment for a broad array of services where you're paid per encounter. And then as you move up into population health payment models, shared savings, shared risk, and capitation, which we'll define in more detail later on. And certainly, as you know, as probably you know, many public policy makers are advocating that providers become more closely integrated and move up the ladder to more and more payment models based on population health and outcomes, to move away from payment models based on volume, like fee-for-service, to that based on value and outcomes. So a national public-private consortium of participants known as the Healthcare Payment Learning and Action Network, fancy name, but basically a group that came together to try to drive alignment across the country and define a common framework for how terms would be used or how you would categorize different types of payment models between providers and payers. And the group wanted a common framework that could be applied to Medicare, Medicaid, commercial payers, all of those, so that people would essentially use a common vernacular and describe things the same way and be able to think about, in the continuum where a potential model falls. And there are 4 categories, and I'm going to describe them in more detail. And I would say most payers and states have kind of conformed to this model, and in their own Medicaid managed care programs might refer to the land framework categories in imposing requirements on managed care companies, with a few exceptions. For example, those of you that are from New York State know that New York State's Medicaid agency came up. They basically follow these models, but they've renumbered them. They got rid of Category 1, and they started here on this slide with Category 2 as their Category 1 because they really wanted to emphasize the move away from fee-for-service and did not want to convey that Category 1 on this slide is any kind of alternative payment model because it's the status quo. But more and more states have used this land framework to define potential payment models between providers and plans. So in the first model, this is, as I mentioned, the status quo. It's just a fee-for-service payment system where you don't receive any adjustments based on reporting data or performance. You simply receive a payment for each service, typically based on the CPT code that you billed. And most policymakers frown upon fee-for-service because it rewards providers for the volume of services that they generate and not for managing individual care. The HCN land framework authors of that document also were uncomfortable or discounted fee-for-service because they really didn't think it was a way that payers could invest in technology within providers. It wouldn't incentivize investments. It wouldn't incentivize innovation or information technology or clinical support tools, as you probably know. Fee-for-service does not typically invest in care coordination functions or those activities or do anything to increase access to care through home visits or group visits or additional office hours. And so there are limitations to the fee-for-service payment model as a whole. From a health center, community health center perspective, the main advantage to fee-for-service is usually predictability. You know exactly in advance for every discrete service that you render how much you're going to be paid. Of course, that doesn't hold up as well in a pandemic. When you're not having as many services, you will have a drop in revenue if you're not having as many face-to-face visits. But generally, the disadvantages that health centers encounter in fee-for-service payment models have to do with the claims-based reimbursement system, the need to have to submit a claim for every service to a payer to get paid, and all the disputes that are attendant to that kind of payment model. where you have claims denied, where you have to spend time resubmitting claims to conform to a particular payer's billing requirement, where you have claims denied and you don't know why, and you have to run down reasons for potential flaws in the claim and resubmit, or track down reasons and find reasons that the claim is, find out what the reason was that the claim was denied, and resubmit it with the proper information on the claim. It can lead to a lot of payment disputes between payers and providers, and delayed payments where you're not paid promptly for services. And it can also involve complications in the event that there's multiple payers involved. So if there's a coordination of benefits issue where a patient has Medicaid coverage as well as commercial pay coverage, of course Medicaid's going to pay last because it's a payer of last resort, and so you might find that out through billing Medicaid. Medicaid denies it, and then you have to bill somebody else, like a commercial payer, have them pay what they want, and then maybe come back to Medicaid to pay for some cost sharing that the commercial payer didn't pick up. But it's labor intensive, and it can be frustrating, and you can end up not getting paid for all the services that you do. So lots of good reasons to not be paid under a fee-for-service payment model, whether it's a pandemic or not. The next model is Category 2. These are fee-for-service payments, but there's some link to quality or value. You have to do something, essentially do something more, and you have a potential to earn additional payments. Now, when HCP LAN updated their payment models, I believe it was 2017 when they refreshed their models, they kind of renumbered and relabeled some of their categories. So if this list looks a little bit different than what you've seen in the past, it's probably because you recall an earlier description of this Category 2, and they've made some changes to it. So now, as of today, Category 2A involves what they're calling foundational payments, which could be, for example, care management fees that you receive, or another kind of monthly payment that you receive as a result of being a patient-centered medical home, sort of these infrastructure payments that the notion is that they'll improve the quality of care or provide additional access to patients, and therefore the payer is basically either incentivizing you to become a medical home or to do that additional care coordination work so that it improves quality. But it's in addition to what you would earn under fee-for-service. Category 2B is pay for reporting, where some payers in the past have provided payment incentives for providers to report quality data. I honestly do not see that very often in contracts between health centers and payers. I don't see them paying for reporting. Some state Medicaid programs and the Medicare program may have had some pay for reporting programs, but in the commercial space, I do not see much pay for reporting 2B arrangements. Category 2C is pay for performance, where you probably have seen where health centers have received additional payments from a payer for achieving certain clinical benchmarks or outcomes. You might have seen references to HEDIS, quality measures, or measures by the National Quality Council, or other groups that have defined measurement sets that payers use in rewarding providers or incentivizing providers to do well. And then you're, as a health center, entitled to these additional payments. In some cases, there's been sometimes penalties where providers would be penalized. I don't see that very often either, where there's actually some kind of money that they take back from provider or some kind of withhold that you have to earn to do well, and then if you don't hit the quality measures, you don't get it. I don't see that very often. Usually these are add-ons. So you get paid under fee-for-service, and then if you hit the measures and the goals that are targets that are set out for them, you then earn additional payments from the payer as a result of achieving them. So pay for performance is Category 2C. I just want to reiterate that because when we start discussing the national trends for what states are requiring of MCOs, you'll see 2C referenced a lot in the description as a value-based payment. Category 3 are our alternative payment models based on fee-for-service. And here again, when the HCP LAN folks refreshed their terminology and categories, they made some changes here as well. So they have two subcategories in Category 3, a 3A and a 3B. And Category 3A is essentially referred to as upside risk, where there's a target based on the total cost of care for an attributed patient population, and then providers are measured against that target that is set out, and then if the costs are actually below the target or projection, a provider can keep some of the savings. It's called shared savings because the provider is sharing in the savings with the payer as a result of meeting the total cost of care target. However, you still as a provider have to meet quality measures. Look at the bottom in blue of this slide where it says very clearly, maybe I should have used larger font, but it has to have a link to quality in order to qualify as a Category 3 arrangement under the HCP LAN Common Framework. If you are just earning shared savings and it's irrespective to whether you achieve quality measures, it actually will not count as a Category 3 payment model. It has to include some connection, something related to quality in order to qualify. So 3A is upside only risk for a set of attributed patients, and we'll talk in a bit about what attribution methodologies look like. Category 3 is shared savings and downside risk. So this is typically referred to as really having upside and downside risk. Sometimes you just hear about this as a shared risk arrangement, and that typically means that you have upside and downside risk based on the total cost of care. So like in 3A, there's a total cost of care target, but in this case, not only does a provider keep some of the savings if the total costs of care fall below the target or the benchmark, but they can actually owe money back to a payer if the actual costs are higher than the target or the benchmark, and you have to compensate a payer for a share of the losses, hence the downside risk. Now, why would a provider ever want to take on downside risk? I mean, you're probably asking yourself if this is somewhat new to you. Why don't I just stay in 3A, safe, where I'm only earning potential upside and no downside? And the answer to that is because the percentage of sharing is typically increased in a 3B arrangement. So, for example, in a Category 3A arrangement with a payer may say if there's savings achieved, the payer gets to keep, let's say, 60% of the savings, and they'll only share with you 40% of the savings. While in a 3B downside arrangement, perhaps the arrangement is 50-50. So now you get 50% and the payer gets 50%, but the cost of that additional 10% of savings that the payer shares with you is that you're now having to take some downside risk as well, maybe on a 50-50 basis with the payer. So the more risk you take, the more upside risk you receive. And that's why 3B is different, and that's why some providers eventually want to move into a 3B shared savings with downside risk arrangement. Category 3B, somewhat confusingly, also includes bundled or episodic payments, where a single payment is made to a provider for all services, typically for a particular condition, and that condition, could be knee and hip replacement. It could be sometimes used as given as an example here for maternity care, something that has a defined start and end point. It may also be in situations where there's like an episode of care, such as for substance use disorders. If there's recovery services that are being furnished to a patient, you could have a case rate for the entire length of the 6 months of substance use disorder recovery services, because that's considered an episode of care. So if you have a bundled rate or an episodic-based payment, that is Category 3B as well. One, I suppose, could also argue that health centers that receive PPS and counter payments, that could qualify potentially as a bundled payment because it's a single payment to a provider for primary care, but it's done on an encounter basis. And so the pushback, I think, from the HCP LAN folks would be that it's not enough to be removed from a Category 1 situation because it's not for a particular treatment. It's really just for a kind of visit. So they likely would not consider it to be a bundled payment, even though, in my view, it is a kind of bundled payment that the center is receiving. Let's next look at some of the arrangements that you might have with a payer under one of these shared savings arrangements. In this example here, you see that the payer has an arrangement directly with an FQHC, And this is a shared savings Category 3A arrangement. And so they have set a target for basically an amount of expenditures for attributed population of patients. And if the FQHC total cost for that attributed population is beneath the benchmark, then the payer will agree to share some of the savings back with the FQHC. So the FQHC has potentially two sources of revenue under this model. They have their base reimbursement, whatever that is, from the payer. Could be fee-for-service, including encounter-based payments. It could be capitation. And then in addition to that, the payers also have a shared savings arrangement with the FQHC, where the FQHC can generate additional payments from the payer if they achieve the savings that are designed and described in the arrangement. This slide shows a shared savings downside risk arrangement, and I have interposed an ACO, an accountable care organization, between the payer and the FQHC. Why is that? That's because we always counsel health centers to consider either setting up their own ACO or being part of another ACO if there's going to be any kind of downside financial risk. Why is that? It's to protect the health centers, protect the health center from incurring any kind of downside risk directly and having a financial obligation that would essentially put the health center out of business. So the idea of having a separate legal entity like an ACO that would incur that downside risk directly, in our view, is a prudent risk mitigation strategy so that that liability does not fall on the FQHC alone. That's why I'm using this example here for shared savings downside risk, where with an ACO and not a direct arrangement between a payer and an FQHC. Though across the country, there are some health centers that do engage in some downside risk arrangements. But our advice would be, especially if you're new to it, not to do that, to have an ACO in between incurring that downside risk instead. So in this model, the FQHC is earning base reimbursement from the payer directly, fee-for-service, encounter payments, capitation, whatever model they decide upon. The FQHC is a participant in an ACO. The ACO is under a shared savings downside risk arrangement with the payer. If the ACO does achieve keeping expenditures below the target for all the attributed population of patients, so perhaps that ACO doesn't include just that FQHC, but other FQHCs or other providers in the community for all the attributed patients to the ACO based on all those providers that are participating in the ACO. If costs are below the benchmark for the attributed population, the payer shares savings with the ACO. In contrast, if there's not a savings, if it costs more than the benchmark, the ACO might owe money back to a payer. In the event of shared savings and there is money that is made to the payments that are made to the ACO determines how to allocate or distribute those payments to the participating FQHCs and hopefully sends additional payments down to the FQHC. If this involves a Medicaid MCO, Medicaid managed care, the FQHC may also be submitting requests for wraparound payments to the state agency, and the FQHC could potentially earn additional payments from the state agency for wraparound payments. Or I suppose if this is Medicare managed care, the FQHC might be submitting claims to CMS for wraparound payments as a result of participation in the Medicare Advantage, which is the Medicare managed care program. There are countless varieties for how payers are attributing patients or population of patients to a health center or to an ACO under an accountable care arrangement. The most dominant model across the country certainly is attribution models based on primary care. So if you are in an ACO, typically the payer will attribute lives to that ACO based on the receipt of primary care services. So for all the providers that are listed as a PCP in that MCO, all the patients that are attributed or listed with that particular PCP, and those PCPs join the ACO, all those patients would be likely attributed to the ACO under an attribution model, which is based on primary care. But that need not be the only model. That's probably the one that you're most familiar with as a community health center or with the ACOs that are in your community, because it certainly is the dominant model. But there are other ways that patients can be attributed to a population that a provider takes risk on. I have seen some models where payers attribute patients based on geography. So they say, and this works well, obviously, in more rural communities where you're the only game in town. But if you're the only provider in town of a particular kind of service, like primary care services, a payer could say, okay, for all the enrollees living in these particular counties, we are attributing all those enrollees to you for care for purposes of this shared savings or shared risk methodology, meaning that it doesn't matter from the payer's perspective whether these individuals actually come to the health center and register as a patient and receive care there. The payment model, the attribution model, is based on the fact that the person just lives in your county, and you're a health center. You are the health center in the patient's county of residence, and now you're being attributed that patient, which is good and bad. It may be good in some sense if you're paid under capitation because you're going to receive dollars for providing primary care regardless if the patient shows up for the visit. On the other hand, in an attribution methodology where you have shared savings and shared risk, you're going to be attributed, or the ACO is going to be attributed that you're involved with for all that patient's costs, even if that patient fails to come to the health center when they're sick, even if that patient goes to the emergency room, even if the patient does not adhere to recommendations for their chronic conditions, you will be attributed all their costs and quality as well. So if the patient's not coming in for the recommended preventative care, you will, and the MCO is evaluating you on certain clinical measures, quality metrics that accounts for those measures, then you're going to be stuck with the performance of these individuals who are not coming to you for care, where you're going to do worse for patients that are attributed but not engaged in care at the health center. So you always have to recognize that attribution methodologies that are usually based on when they don't get care from you. They're based on geographic area or who their assigned PCP is, or based on the health diagnosis, and that results in a few quirky things to kind of keep in mind. So that's what I've tried to point out here at the lower part of the slide is that, say for example you're attributed a population of patients, and it's based on last year's claims data for where that patient went to care. Well, let's say this year the patient has not visited you for care. You're still attributed to them, even if they came to you last year. Therefore, they're attributed to you. But this year they're just showing up in the ER every day, or they're going to another provider. Too bad. From the payer's perspective, the attribution methodology was based on where that patient sought primary care last year. And so they are, which was you. So this year, the current year, they are continuing to be attributed to you because they have a prospective attribution system. They're looking at past claims to do this year's attribution methodology prospectively. It can also result in some funky things because it can include patients who have received services from you in the past but who are actually assigned to a different provider. So you may have patients who you are providing in this current year, but they're actually being attributed to a different provider because last year they went somewhere else. So one thing I would strongly recommend, and we'll point a little bit of these things out when we get to the third webinar in this series about contractual protections, is to actually request from the MCO the list of patients that are attributed or would be attributed to you under the methodology. So you can see from time to time the disconnect between a prospective attribution based on where patients went last year and the patients who you're actually seeing this year in which you would be evaluated under, because the performance year, this year's attribution, determines whether you can earn any shared savings, even though the attribution methodology takes into account where patients went last year. So a little bit, it's a little bit confusing because it's very complicated when you start talking about attribution methodologies and the kind of quirky results that can occur. All of you will probably, or many of you might be thinking, it would be far better for us if we were just attributed to the patients who are actually engaged in care right now, this year. And you're right, it would be a lot easier. But from a payer's perspective, that doesn't necessarily serve the payer's interests. The most expensive patients probably are those that are not actually engaged in your care. I have confidence that once they're engaged in your care at the health center, you're doing everything in your power to prevent the patient from seeking care in the emergency room, or or having hospitalizations that can be avoided. But the payer's most expensive patients are probably those enrollees that are not engaged in care with a provider. And so payers have a very strong desire to attribute these patients, those that are not engaged in care, also to you. So you can take, they think, more proactive steps to reach out to them, involve community caseworkers or community health workers in the community to try to engage those patients in your care to deal and manage the total cost and the high cost for those unengaged patients. When you have a benchmark, when the MCO establishes a methodology for establishing the benchmark for what it's going to cost them, they do it in a few different ways. Some might just look at it on a basis of premium revenue. So they may say, we expect that because we have to spend 85% of our premium dollars on claims, so we're going to establish the benchmark for this shared savings, shared risk methodology based on 85% of the premium dollars we get. So if the actual claims experience that we incur exceeds 85%, so we're paying more on claims than the 85%, then there's going to be a loss. We're not going to share, the payer's not going to share any money with you. But, however, if you keep the cost of claims down, so it falls below 85%, we'll share some of that savings with you. That would be a percentage of premium revenue as a basis to set the benchmark. Other payers might just directly talk about a medical loss ratio, which is the amount, again, they spend on claims for providers at 85%, or maybe they want it down at 75% or 80% to try to generate the kind of margin on their premium that they desire. Others might look to a total cost of care on a PMPM basis, so based on claims experience, and then project it forward. So there's all sorts of ways for the payer to establish the benchmark that is used in their shared savings or shared risk methodology. But a couple of quick practice pointers. It's incredibly important to understand how the payer is establishing the benchmark. If the payer sets it too low for you, it will be virtually impossible for you to generate any savings against it under a shared savings arrangement, or you'll quickly incur those downside losses under a shared risk arrangement. You really want to set the benchmark as high as possible in order to allow you to generate savings against the benchmark. So a benchmark here should make sure it should include any types of one-time payments that the purchaser, like the Medicaid agency, makes to the MCO for certain life events like deliveries, additional payments so that the payer might be paid from a state that cover graduate medical education, FQHC, wraparound payments if the state is delegating the payment of the full encounter risk to the MCOs, whatever else. You want basically to throw everything in the kitchen sink into the establishment of the benchmark, because you want the benchmark as high as possible so that you have the greatest potential to reduce claims and achieve that savings under the benchmark. In contrast, you really want the allowed spend. So this is how the MCO calculates the claims against that benchmark to be as low as possible, because you don't want that to be driven up by things that are outside of your control. So you don't want, for example, a payer including their own administrative costs as a payment against that benchmark, or vendor payments that they make to third parties to pay certain types of claims, or quality improvement, or provider bonuses or incentives. You don't typically want that included in the allowed spend, or whatever language the payer uses to describe those amounts that count against the benchmark. Some payers even allow you to exclude high-cost members from counting as the allowed spend. So members, for example, that might have total expenditures of claims in excess of $100,000, an outlier. These outlier claims, in some cases, can be removed by the MCO in determining whether your total costs of care are below the benchmark. That's generally a good thing for you when the outliers that have high claims costs are removed and don't count against the benchmark, because you want the allowed spend to be as low as possible to qualify for the shared savings or avoid any downside losses. Category 4 are population-based payments, and the refresh also changed these subcategories, A, B, and C. 4A are what's called condition-specific population-based payments, and these are actually the types of payments where they're bundled typically for a certain condition. So in Category 3, we were talking about episodes of care and clinical, clinical situations, procedures. Category 4A involves what they talk about as basically broader situations, so types of illnesses or conditions. So if it covers all the costs for cancer, that would be a Category 4A. If it only covered chemotherapy payments, that would not be 4A. That would just be possibly a 3B type of payment. So if you're only paid for primary care, like you have a primary care capitation arrangement, that would qualify as Category 3A because it's based on a particular provider's scope of practice. If it only included behavioral health, that would also be 4A. And I suppose if it included both behavioral health and primary care, that would still only be categorized as Category 4A because it's based on a defined scope of practice. 4B is when a payer and when a provider is basically accountable for all the costs of services for an individual's health care needs. So we're talking about full risk arrangements where usually an entity, not a health center like an IPA, is accountable for both hospital and physician services. That would be 4B. 4C is kind of a new category that HCP/HCLAN added for integrated delivery systems, like entities like Kaiser Permanente, entities like insurance companies and providers that have come together, like the University of Pittsburgh Medical Center, UPMC, which has UPMC Health Plan, or Allegheny Health Network and Highmark Blue Cross Blue Shield. These are vertically integrated arrangements between payers and providers, where they they collaborate in an integrated delivery system that involves the integration of finance and a delivery organization, and they're usually pairings between an insurance company and a provider system. Those have their own separate category as 4C, and that's supposed to be basically an acknowledgement that these types of delivery systems offer the greatest potential for population-based payments arrangements to work because it has a payer and it has a provider closely working together in these systems. And just like Category 3, there must be a connection to quality in order for the arrangement to qualify under Category 4. So by way of an example, let's say you have an FQHC that's paid primary care cap. That's a Category 4A arrangement because the MCO is simply paying on a per member per month basis the services that the FQHC provides that are related to primary care. Some health centers actually get paid on a professional cap basis, meaning they get paid for a defined portion of all physician services. But sometimes those physician services also include services that the FQHC does not directly furnish. In that case, like the slide indicates, an FQHC might go out and actually contract with some specialty physicians so that they are then paying those specialists out of their capitation payments that they receive from the MCO, because that is a professional capitation arrangement. The FQHC is getting paid for a broader scope of services, not those that they just provide within their four walls, but also other physicians' services that they pay using the capitation dollars that they receive from the MCO. And then I guess theoretically, though I don't advise it, the FQHC could be paid under full capitation, where they receive a broad, large PMPM, per member per month amount to cover all the health centers, all the services provided to enrollees, hospital and physician services. But again, in that model, we would highly recommend that you have an IPA or an ACO, an intermediary that is receiving that capitation payment for that broad scope of services, so a health center does not incur that risk directly. And then hearkening back to COVID-19, to the pandemic, clearly a number of health centers who are not paid under any kind of capitation model are looking very favorably now at models where they might be paid on a primary care cap basis and receive a fixed amount of payment every month for an attributed group of enrollees without having the requirement or the need to generate face-to-face visits and encounters due to all the restrictions related to COVID-19, or the fact that some patients are simply deferring treatment and not coming into their primary care physician for care. If you were paid on a primary care cap basis, it avoids the patient having to come in order to generate the payment, because the MCO is paying you each month for what they expect the volume of services to be, not the actual utilization of services by the patients. So you basically are taking some risk, because there may be a time after we get through the pandemic that there will be a surge with many patients coming into the health center again for services, because there could be some pent-up demand. Patients who have not come in for their recommended preventative care, or particularly children who are expected to have well child visits who might not be coming in. I've heard that many health centers are struggling because children are not coming in for recommended vaccinations. So there could be some pent-up demand later on where utilization actually increases. Well, under a capitated payment model, you get the same amount each month regardless of the amount of utilization in that particular month. So a health center is still taking that financial risk that at some point in the future, even though there might be some windfall in the current month due to lower utilization due to the pandemic, things could catch up and change in a few months when patients start coming back in if they exceed the amount of visits that are anticipated under the capitation arrangement. So as you can see from this discussion, engaging in a capitated payment model requires you to really be thoughtful about the expected utilization, how many times do you expect patients to come in the course of a year or in the course of a month for services from the health center, and whether the PMPM amount accurately or correctly compensates you for all the costs of services for the expected utilization of services that you're delivering that capitation payment is based on. Because I'm sure that you or the payer has calculated for each year how many times they expect their enrollees to come in for primary care, whether it's three times a year, 4 times a year, or 6 times a year, depending on that particular patient's chronic conditions or otherwise. There are some cases where capitation payments are actually vary in some cases based on they're risk adjusted based on the patient's age or gender, or even to particular types of conditions. So as you look at the capitation model, some of these are based on a percentage of premium again, while others is just based on a PMPM, a per member per month amount based on claims experience, how many times the patient comes in for services by the health center, what the likely payment on an encounter basis might be, and then converting that to a capitation model. So if you pursue a capitation methodology, consider the fact that you need to be thoughtful about the scope of services that are subject to the benchmark or to the capitation amount, because you want to know exactly what you are engaged to provide. So if the MCO believes that they're covering a very broad scope of services of primary care, and they include things that are some specialty services in your mind, but they base the capitation model on a certain scope of services, and you have something else in your mind about what the covered scope of services are, that can lead to disagreements later on where you're saying to them, no, that's not part of my scope for that capitation dollar, and they're coming to you expecting you to provide a service because it was under your scope in their view that you received capitation dollars for. So usually in these arrangements, it's very important to have a clear definition of the services that are paid for under the capitation amount. As I mentioned, you may want to consider risk adjustment for capitation that are specific to particular populations. And then you always have to be thoughtful about whether there should be additional adjustments later on and how those adjustments are reflected in changes to the capitation methodology. What happens if the state makes a retroactive enrollment decision? So, 6 months later, they decide that 3 months ago somebody wasn't eligible for Medicaid, and the managed care company then takes back the capitation payments from you for all the services you previously provided to patients, and then you're stuck and you can't bill that patient, or now that patient's uninsured. You're not going to recoup those dollars from the patient, and you've basically lost money because the MCO is taking back their capitation payments because there's been a change in eligibility. Or is the MCO going to take money out of your capitation rate if a patient doesn't come to you for primary care and they go to your neighbor down the street, your competitor down the street, and the MCO pays the claim because the patient had the right to go to that other provider for care, but now the payer is deducting from your capitation the amount that they paid that other provider, your competitor, on a claims on a fee-for-service basis. So I've seen take-backs or chargebacks to health centers where MCOs deduct amount from capitation payments due to amounts that the MCO has paid other providers for claims related to the services that you were paid for under the capitation. So that's sometimes called leakage when that happens, when you get paid for a scope of services for particular patients, and then those patients go elsewhere for services. And also, of course, what happens when the capitation rates increase in the future? Let's say a payer increases the capitation, the state increases the capitation rates to the payer. Do you automatically receive a change in those capitation payments that you receive as a result of the adjustments in the premium? Hopefully, but it would all be defined under the arrangement with that payer. In the last 10 minutes, I just wanted to share some highlights or some trends that I've seen across the country related to how states incorporate value-based payment models or risk-based payment models in their managed care contracts with MCOs. States, have a variety of ways how they will incorporate value-based payment and risk-based payment models into their models. I'm actually going to show the next slide, because I think the next slide is actually the most interesting. What you have on this slide are examples of particular states and how the state has drawn the line at what qualifies for a value-based payment arrangement. And as you can see, there's some commonality, and a number of states have looked at Category 2C as the basis for determining what a value-based payment arrangement is. And this slide is actually up to date now. So 2C, remember I said this would come back to us, is pay for performance. So most states have used Category 2C, value-based payment, as the definition of value-based payment. So pay for performance has counted as a type of value-based payments that MCOs had to achieve under their contracts with payers. One outlier, as you can see, is New York, who started the definition of value-based payments as 3A, which is a shared savings model. So they were much more aggressive in setting the definition of value-based payments. They set the standard higher in New York for what would qualify as a value-based payment. And then what do they do? Let me show you a few slides here in the remaining time for what states typically have done. Washington State is a good example of this. Their Medicaid agency called the Health Care Authority, they set a requirement where 90% of state finance payments to providers, meaning that is the MCOs that provide and arrange Medicaid services, had to have 90% of those payments going to providers in APM categories 2C through 4B by 2021. And they set these targets for achieving that, and then they basically withheld a percentage of the MCO's premium based on how each MCO did in achieving the target that was set. So, for example, they said you can earn back a percentage of the withhold depending on whether the MCO meets that target. So if the MCO had to achieve, let's say, 80% of their payments to providers had to be in categories 2C or higher. So it could be pay for performance or higher, meaning that an arrangement, a shared savings arrangement or a capitation arrangement, that would count as well. The plan simply had to have at least 85% of their payments in a particular year. They had to be in 2C or higher. Then the MCO would be able to receive, let's say, 75% of their capitation arrangement withheld back from the state for achieving the provider incentives target. And then there was some, and Washington State was a little bit unique. Then they also allowed the MCO to earn back some of the other withhold based on other categories or other targets that they set. So the first target I just talked about was the percentage of payments in a VBP arrangement. The next one had to do with the VBP provider payments that were in the form of an arrangement. So they looked at all the payments that were made to providers and what percentage of those were in a particular payment category. Then they had two other targets, quality improvement scores. So again, this harkens back to the fact that in order to have a Category 3 or 4 arrangement, it has to involve quality to some respect. And those MCOs that performed well enough on those targets earned another percentage of the withhold back. And then actually, if the MCOs if some MCOs did not earn all their withhold back, the state created a fourth quality, they call it a challenge pool, and MCOs that did really well could earn additional dollars back from withholds that were not earned back from some of the MCOs, and could earn these additional dollars for these challenge pool incentives. So they were creating very strong incentives for the MCOs to move to value-based payment in their arrangements with providers. Oregon is doing something somewhat similar. You'll see over the years 2020 through 2024, and incrementally each year they require a greater share of the, in the Oregon parlance, it's a coordinated care organization, not an MCO, but a CCO, much like an MCO. Each of these entities have to have a certain percentage of their payments to providers fall within land categories 2C or higher, based on what year it is, and they're trying to push those payers to do that. And then you can see at the very end, by 2024, they have to have 70% of their payments to providers in 2C or higher, and no less than 25% of payments in categories 3B or higher. So they have upped the amount every year through 2024. And then Oregon's done some other unique things where they've actually are requiring the CCOs to focus on certain categories. They call them delivery areas. So I think here they were concerned that these VBP arrangements would only occur perhaps for physical health services and primary care. So they actually required the MCOs to develop some of these VBP arrangements in non-primary care areas, so affecting hospital care, maternity care, children's health care, behavioral health care, and oral health care, so that some of these other areas would have access to these types of VBP arrangements. They also have a foundational payment, so that would be a Category 2A arrangement, where they are requiring the MCOs to provide these per-member, per-month payments to patient-centered primary care home clinics. That's their language in their contracts, to these clinics, in addition to the payments that they're making to providers. Just moving ahead here, so New York, as I mentioned, they set the definition at level 3A, which is shared savings, and they said by April 2020, which I know has passed, at least 35% of those payments had to be in level 3B, so that's downside risk. So there's a huge push for the fully capitated plans in managed care in New York State to meet these payment targets, because if they did not, then those MCOs would actually face financial penalties. And as you may know, in New York State, if the state failed to meet those same targets, CMS theoretically or in reality could refuse to pay New York some of the additional payments that were under the state's waiver with CMS that allowed the state to draw down additional federal funds. So it's important to know that health centers are very, very attractive partners for accountable care arrangements, for value-based payment arrangements, because all the research studies have shown that the total cost of care for health center patients is lower than had those same patients gone to other non-FQHCs for services. So that's one of the biggest selling points that health centers have for engaging with payers or forming their own ACOs or trying to participate in existing ACOs, is to say, we can bring to you savings from the get-go, because once you receive our attribution, once our health center patients are attributed to your ACO or attributed to our ACO, if you're a part of one and you formed one, you potentially can do really well financially, because the total cost of care for these patients are typically less as a result of going to the health center than these same patients going to non-health centers for services. So there is data on the NAC website that shows the results of some of these academic research studies and compares health center patients against non-health center patients and the total cost of care. Some of these studies, like this one, is particular to just, I believe, Medicaid. Other studies relate to the Medicare population and compare the total cost of care for patients that are seen by health centers to those seen by physician offices and outpatient clinics. So I didn't really leave too much time on this webinar, unfortunately, for questions. I think we only have a minute or so left, but that is the content I wanted to share today. I think I will bounce it back to Jen to wrap things up and see if there's any questions from the participants.
Hey, Adam, this is Julie. We haven't gotten any questions in the chat box, so I will remind folks that we have 3 additional webinars in this series where there will be an opportunity, especially the 4th one, to ask questions and have your questions answered. So looking forward to those, and I will turn it over to Jen. All right, I think Jen is muted, so I will just put this slide up with the next few webinars. Don't forget to register. Tanya, I apologize. Let me unmute you. It looks like you have your hand raised for a question. You are
Hello?
unmuted.
Can you hear me?
Yes, we can hear you.
Yeah, it wouldn't let me put the question in the chat box. Will these slides be made available via email or on the website at any point?
Yes, these slides were sent to all registered participants. They will also be posted along with an archived recording of today's session, and we will be sure to send an email notifying all attendees, and it will be posted on NAC's website.
Okay, thank you so much. That's all I wanted to know. It was very informational. Thank you.
Great, thank you. Jen or Susan, Adam, anything else? If not, thank you everyone so much for joining us and for taking time out of your very valuable days.